All right, thank you. So nice to see you guys. I know most of you on this call, but my name is Mark Peterson, and I'm on faculty at University of Michigan, Department of Physical Medicine and Rehab, and I will be giving you some insights into our most recent work regarding pain phenotyping in adults with CP. Dr. Hurwitz and I just recently wrote and published this perspective piece in Mayo Clinic Proceeding. I won't read it to you here, but just as a sort of cliff notes, we tried to talk about and summarize the state of the literature and the state of the field in regards to research pertaining to adults with CP, clinical care pertaining to adults with CP, and perhaps ways in which we need to move and continue to move forward to amend policy so that individuals with CP, as they grow up, continue to receive appropriate care. This slide, I just put this in here because it's interesting to look at the landscape of literature published from the first paper ever published on adults with CP was in 1953. And you can see there's a very large increase over the last, especially the last 5 years. In fact, the vast majority of research has been published on adults with CP in the last 5 years. And surprisingly, in 2020, during COVID, we almost did as well as in 2019 with only fewer publications. So I can say that this is a really ripe and new area of research, and I'm hoping that it continues to increase. Some of the work that we have been doing has looked at chronic disease surveillance in adults with CP, specifically in regards to non-communicable diseases related to aging. And we have almost studied every organ system at this point to examine the extent to which adults with cerebral palsy experience accelerated aging phenotypes. And what we have found is that, lo and behold, pretty much across all organ systems, we know there is increased risk for age-related chronic disease and multimorbidity. So some outstanding questions that we have is based largely on sort of clinical vignettes and patient-reported issues are related to pain experiences, chronic pain, especially chronic overlapping pain. Given that pain is highly associated with chronic disease and is also highly prevalent in individuals with CP, we are really interested to know, is chronic pain causally linked to psychologic morbidity? And also, what is the prevalence and phenotype of chronic pain in CP? To the greatest extent, pain has been sort of characterized as stemming from musculoskeletal origins, peripheral pain specifically, but we have started to think outside the box a little bit and start to try to understand sort of the mechanisms of pain that might be above and beyond just peripheral related musculoskeletal origins of pain. Because understanding mechanisms of pain is very crucial for the appropriate and effective management and treatment of pain. So Dr. Daniel Whitney, who you'll hear from here momentarily, did a study this past year, which was published in DMCN, so I don't have to go through the results. You can find the study, but basically looked at the effect of pain on mood affective disorders in adults with CP. And what he found was adults with CP who had new pain. I'm sorry, I gotta move this little thing so I can see. Oops. New pain or co-occurring pain had a much greater crude incidence of mood affective disorders as compared to adults without pain. And the elevated rate of mood affective disorders remained even after adjusted for co-varying new pain and consistent pain. So there's clearly a link between chronic pain, and this doesn't get at the mechanism of pain, but chronic pain and mood affective disorders, which probably doesn't come as any surprise, but it had previously not been studied in this population. We have most recently been able to do some pain phenotyping in adults living with cerebral palsy and spina bifida using administrative claims data from privately insured individuals. And this paper was, I'm happy to say, was just accepted for publication this week in the journal Pain. And so this will be the first study of its kind to look at a large population representative sample of adults living with CP to try to understand the phenotype of pain. And so we had a large sample of adults living with cerebral palsy and spina bifida. You can see over 22,000. as compared to adults without CP in spina bifida. And we looked at prevalence estimates of common pain types and pain multimorbidity, and specifically also looked at adjusted odds of nociceptive pain, nociplastic pain, and neuropathic pain, which I will describe. So at this point in the state of the literature with regards to pain, 3 distinct types of pain have been identified in pain literature, and that is nociceptive pain or pain due to direct tissue damage, such as musculoskeletal pain, which has been the primary focus of pain in CP historically. Neuropathic pain, which is pain due to damage to the somatic system, such as neuralgia, neuritis. And then most recently, nociplastic pain is pain due to central sensitization of pain. And this has been very much more recently developed than the other types of pain, and is more specifically centralized pain, central hyperalgesia, where there's an amplification of pain processing, pain experience in the central nervous system, for example, fibromyalgia, chronic migraine headaches, irritable bowel syndrome, and so on and so forth. And so this has been designated as essentially a new type of pain that is more of a centralized mechanism related to overall pain. What we found was that adults living with CP or spina bifida had a higher prevalence of any pain, so you can see just over 55 or 56% versus 35, and pain multimorbidity, multimorbidity being 1 or 2 or more types of pain, 21.1 versus 8.4 as compared to adults without CP or spina bifida. And the differences were clinically meaningful. In other words, they had, to an extent that would be an effect size that would be to a clinically meaningful extent different. This is lower than the mean pain prevalence recently reported by Vanderslot et al. In a large meta-analysis, which found that pain was reported to be across many studies to be about 70%. We may have found a lower prevalence of pain in our administrative data because pain is not diagnosed as often. And in the claim, it certainly is probably an underrepresentation of true pain in CP. And so what we found was that the crude pain prevalence in CP versus controls was for nociceptive pain, so that's again peripheral pain, is 44 versus 26.7. Nociplastic pain, again, that's centralized pain, 26% versus about 12%. And then neuropathic pain, a little lower, 9.6% versus 5.6%. And then after adjusting for sociodemographic variables, including age and gender, geographic region, income, education, and various other sociodemographic covariates, we found that adults with CP or spina bifida had a much higher odds ratio for all 3, nociceptive pain, nociplastic pain, and neuropathic pain, demonstrating that, clearly they have much higher risk for pain, but also pain is arising from other mechanisms besides just a peripheral mechanism. So then we decided that we would extend our work, doing a little deeper dive into the pain phenotyping in just adults living with cerebral palsy who experience pain. And so at the University of Michigan, we collected a cohort of a sample of 71 adults with CP who presented for chronic pain in the chronic pain clinic. And so data were prospectively collected using the Michigan Genomics Initiative and analgesic outcome study, and we were able to identify adults with CP. So we did a deeper dive pain phenotyping using validated questionnaires that could get at different types of pain. Neuropathic pain was assessed using the Pain Detect questionnaire, which is a 13-item survey to determine the presence or severity of pain of the neuropathic origin. And you can see that there's a cutoff of 19 that would be evidence of neuropathic pain. We also used a measure to get at nociplastic pain, so the degree of centralized, centrally enhanced pain processing was assessed using the American College of Rheumatology 2011 fibromyalgia survey. Evidence 13 or higher on the score is fibromyalgia diagnosis. The median, we used a median of 6 and or higher, which would be evidence of centralized pain. And so that's a validated questionnaire that can get at the centralized mechanism of pain and of fibromyalgia. We also measured stress, depression, and pain intensity and anxiety. Stress was measured using patient-completed perceived stress scale. Anxiety and depression were measured using patient-reported outcome measurement information system using PROMIS. Short-form measures of anxiety and depression, and then pain severity was measured with the brief pain inventory, which assess overall current pain, average, least, and worst body pain in the past 24 hours. Again, all three validated pain, anxiety, and stress measures. What we found was that the vast majority, you can see 39% in the blue, was lack of evidence for neuropathic or nociplastic pain, which was then coined nociceptive pain. Again, these were individuals who were being seen for pain. So if they did not have evidence of neuropathic or nociplastic pain, they inherently had a nociceptive diagnosis. And then you can see the larger piece of pie with in orange at 34% was evidence of nociplastic pain. So again, centralized pain, but no evidence of neuropathic pain. The green sliver is 11% evidence of neuropathic pain, but not nociplastic pain. And then yellow, 16% evidence for both neuropathic and nociplastic pain co-occurring. So importantly, the combined prevalence of nociplastic and nociplastic plus neuropathic pain was 50% in this population. So this is a fairly novel finding, given that, again, historically, pain in CP has been almost exclusively attributed to peripheral mechanisms stemming from spasticity, orthopedic conditions. And so I think we owe it to our patients and certainly the field to try to better understand the pain phenotype in not just adults living with CP, but perhaps even in children who have pain. So our additional sort of secondary analysis here was that we did some hierarchical regression analysis. We showed that scoring positive actually for nociplastic pain predicted significantly worse self-reported depression and perceived stress above and beyond the effects of pain intensity. And so this is important because, again, we are able to show for the first time that centralized processing of pain seems to be highly associated with both depression and stress in this population. In contrast, scoring positive for nociceptive and neuropathic pain types did not significantly predict any depression, anxiety, perceived stress. So some ongoing and future directions, as I kind of conclude here, is that we'd like to do deeper phenotyping using quantitative sensory testing to examine if individuals with CP and centralized pain exhibit global hypersensitivity to painful and non-painful stimulation. That's been done extensively in the general population, but had not yet been done in CP. We'd also like to understand the individual patient pain process and lived experience, as well as provider level variation in behavioral factors that influence pain treatment, specifically across insurance subtypes and geographic regions of the United States. And then lastly, and we're currently actually doing this study, is to determine the prescribing patterns of opioid and other morphine equivalents for treating pain in CP, as well as to examine the extent to which pain intervention polypharmacy is related to morbidity and mortality in this population. And as a kind of a brief snippet of what's to come, we're finding that in some cases, adults with CP are being prescribed up to 5 times an oral morphine equivalent as compared to adults without CP. So this may be a really important issue that we should try to uncover and try to better understand. Certainly will be affecting their not just more morbidity, psychological health, but also perhaps be a cause of premature mortality. So with that, I thank you guys very much, and I am happy to take questions now. I try to go as quickly as I could. And I'm also happy to provide ICD-9 codes upon request.
Yeah, thank you, Mark. Steve Korzynski wants to know about if we looked at race at all. There's some non-CP pain literature about race, pain, and sequelae.
So what was the question, Steve?
About race. Did we look divided by race?
I mean, I accounted for race in our study. I can't give you off the top of my head what the signature
might say look for differences by race, because you might pick up more funding streams by that, because there's a lot of interest outside of CP where they look at whether or not people are accommodating or receptive to reports of pain from different types of patients. So you might be able to place your work in that context and go to another funding mechanism as needed. So
That's a really good idea. Thanks for that, Steve. Appreciate it.
Satan asked a question about, is pain in adults caused by some intrinsic pain threshold change or sensory neuronal change or CNS change, postural change, muscle change? Mark, I'm going to answer this for you. We don't know.
Thanks.
So Sid, we need to look at all those things and to find out. So, all right, Mark, thank you so much.